Good morning. How's everybody today? We have a great audience. I think there are probably still people milling out in the hall, but I'm sure they'll come join us. My name's Susan Hanrahan. I'm the Dean of the College of Nursing and Health Professions. I want to welcome everybody to our third annual Delta Health Disparities Conference. I'm going to talk to you a little bit. I'm going to talk you through the program here in just a little bit. But I want to have you raise your hand if this is your first Health Disparities Conference at ASU. So we have a lot of new people. Who are our returnees? Good. Well, thanks for coming back. I think you're in for a treat, as I'll talk about in a minute. Let me first, though, note that it's Veterans Day, and I hope you'll take the time to thank anybody that you know for their service to our country. And remember, those who are currently serving, keep them in your thoughts and prayers. A very special day. All right, let's talk about the program for a minute if you have it in front of you, because as I was looking through it, it's very, very impressive. And first on the back, I want to thank our planning committee, who our conference co-chairs were Dr. Walls and Dr. Wilkerson. Dr. Walls is here, and I don't know if Pat's in the audience. Patricia, are you in the audience? Okay, but great job on this, and certainly want to thank all of our sponsors. I'll talk about our keynote in a minute, who is one of the first people there, but then after our keynote you have two choices for the rest of the day on conference programming, and all of those are absolutely sensational. Ms. Fullen is the chair or the director of our Title IV Child Welfare Program, and she's going to be talking about youth. That's a great choice. Disparities in Mental Health Services is another one. Dr. Taylor and Dr. O'Day and some of their students are going to talk about that, so you have to choose between those two. After lunch, you've got a diversity inventory workshop. Matt Knight is one of our friends from Mid-South Health Systems. That's an excellent piece, as well as combating ageism and health disparities with geriatric rural health population. Dr. Long is one of our new social work faculty, and I think that will be exciting as well, especially if you have interest in the geriatric population. After them, there's a panel of individuals. It so happened I heard them speak in Little Rock yesterday. They're going to bring in some qualitative data on the Delta area, and I think that's kind of fascinating, very intriguing, interesting information. But at the same time, Dr. Morrison is talking about screening for community-dwelling older adults, health and wellness needs. She is she's our new chair for our occupational therapy program, and I think that will be a fabulous piece too. So I feel sorry for you to have to figure out which session you're going to go to after our keynote and for the rest of the day. There's also a survey at the end. We want you to evaluate our conference and let us know what you liked, didn't like, and what we might want to do different in the future. So we value your input. Last year I was able to introduce Chris Massengill, who is the head of the Delta Regional Authority, and if you followed any of the stuff that they're doing, it's absolutely fabulous relative to health and wellness and economic development and all the pieces that they're attending to in our Delta region. And this Health Disparities Conference is particularly important for our Delta region, our dental health and wellness. Our Delta Health and Wellness. We know if you look at morbidity and mortality, the statistics are deplorable, and there are a lot of significant needs that we need to help with now and into the future. So it's very important that you kind of understand those, frame those, and figure out how best you can provide support and assistance. I think people are getting tired of us telling them what to do, and so they seem to be less compliant when we put out this elaborate plan for them and say, this is what is going to make you better. I think maybe our better strategy is to find out what they want to improve and how we might help them toward that end. So they have to take some ownership in their health, and I think that's one of the biggest missing pieces that we're seeing in our population today. So, without further ado, and I know she's going to talk a lot about this, Dr. Barbara Ross-Lee is probably our newest person on our campus. She's actually going to be the founding dean of our New York Institute of Technology College of Medicine at Arkansas State. So we're starting a brand new Doctor of Osteopathy program. She is the founding dean. If you'll read, you have her vita just like I do. But let me point out that she has held some significant positions at NYIT. And in addition, If you read the second paragraph, this is why she's here. She's a nationally recognized expert on health policy issues, serves as an advisor on primary care, medical education, minority health, women's health, and rural health care issues at the federal and state level. So very broad base of understanding. She does a lot of work with the Osteopathic Association, the Health Policy Fellowship Program. She does things for the Institute of National Health Policy and Research, et cetera, et cetera. Most importantly for today, she served as a commissioned officer, United States Naval Reserve Medical Corps, achieving the rank of captain. So, without further ado, it is my pleasure and privilege to welcome Dr. Barbara Russley.
Good morning, everybody. Well, this is a little bit different. I usually can tell when I'm giving a presentation in an academic setting because absolutely everybody sits in the back of the room. But today, clearly, we have some brave souls who are sitting a little bit further. Either that or you don't like the people back there. Okay. Well, good morning. I am very pleased to be asked to deliver the keynote address on this very important topic. Health disparities, transforming healthcare in the Delta. Transformation is not by any means an easy job. Get this closer. But clearly, the conference attendees acknowledged by their presence that this is an important task at hand for all of us to watch and contribute to. I'd like to thank Dr. Hanrahan and Dr. Walls for inviting me to speak, so thank you very much. Whenever I speak, I establish 3 goals for myself, and I hope to achieve at least 2 of those. My first goal is, oops. I'm giving away my secrets here. There we go. My first goal is to be informative. I'm hoping that I'll provide you with some information that you didn't already know before you got here. And my second goal, I hope to be provocative. And that's so you'll remember I was here today, but more importantly, to provide some direction, a different perspective, to force you to think and look at issues of health disparities a little bit differently. And finally, I hope to be engaging, which means I don't plan to talk at you. I want to talk to you. There we go. Okay, how do I get the big picture back? Here's somebody. Okay. Got it. Oops.
Click it. Where's Peg?
Here it is.
Come here.
Here we go. Okay. Didn't.
We just do this.
I knew you were gonna help.
Wait a minute, let me
Take
put
these
you
off so I can see that.
There you go. How about that? Is
Yes.
that the way you want it?
Yes, let's go back up a little bit. There we go. Okay. Yes, I got it. I got it. Yeah, well, you can. Jeez. Okay, so okay. Find out where I am. I apologize, folks. Here we go. The inequities and disparities in the U.S. healthcare system, particularly as they relate to health vulnerable and minority populations, have been a scandal of such long standing that they've lost the ability to shock. lost the ability to shock our nation, our region, our state, and sadly, even our society. Without solutions, we run the risk of continued complacency and ingrained acceptance of a persistent and increasingly unhealthy segment of the American population. And all projections say that population is growing. So by 2030, it's expected that today's minorities will be approaching majority status. I sometimes wonder what we're going to call them once they become majorities, because they carry with them a heavy burden of disease. We have worked hard to document the problem and its impact on all Americans, particularly vulnerable Americans. You just do a literature search, and you find that nearly every medical intervention and disease has been studied, resulting in repeated reports of inequities and health disparities for minority populations. Each of us brings a unique perspective to designing solutions for the issues related to health disparities. Our perspectives determine how we see the world, the questions we ask, and it's formed by our experiences, our heritage, our culture, our economic status, and our education, whether that education is formal or informal. Even in this age of a rapidly expanding biomedical and technologic knowledge base, scientific excellence, medical achievements, and quality health care are only limited by limiting the perspectives which contribute to the discovery process. Perspectives are important to solving entrenched problems. This is the power of diversity. So let's just look at 3 perspectives that aren't even in medicine. But those perspectives have been powerful enough to change society in ways in which we couldn't even anticipate at the time. For instance, Einstein. Einstein's theory of relativity is based on the premise that viewing an event from different positions results in seeing the event differently. I'm sure you students didn't expect a lecture on Einstein when you came in here this morning. The corollary to this theory is that by analyzing the different views, the event can be more accurately defined. I'd like to carry that theory even further. Certainly further than Einstein intended, but what an individual sees depends on his or her perspective, which infers that each person's perspective is important and valuable in defining the event. Second powerful perspective. Reverend Martin Luther King Jr. His leadership brought forth a civil rights movement in a nonviolent manner, and clearly, I can't see up here. Is there a light up here? Does anybody know? That's my problem. decided not to struggle anymore. Okay, here we go. Most of us, however, don't realize that civil rights was just one focus of the Reverend King. In fact, he had several objectives that he was attempting to achieve. His vision, or his goals, were to achieve social justice, but also educational and economic opportunities, and health parity for all Americans. And he spoke about these issues many times. But it was the civil rights movement that he achieved the greatest success. And I quote the Reverend King when I say, "Of all the forms of inequality, inequality in health is the most inhumane." And then our third diverse perspective is Malcolm Gladwell. How many of you have read his books? Nobody? Ah, okay. How many of you have heard the term tipping point? Ah. Malcolm Gladwell is a journalist and author. He wrote the book Tipping Point and Blink, and his most recent one is David and Goliath. I suggest that all of you students pick up one of those. It's very interesting reading, and it presents a perspective unlike any that you will have encounter. And ultimately, he shares with his readers a unique perspective that observes and puts the work of researchers on subject experts into a framework that even lay people can understand. He creates an explanatory flow that allows us not only to understand the issues, but be able to creatively begin to come up with solutions and problem solving. These are some of the different perspectives, and each of you has the ability to do the same thing. Designing solutions requires a base of knowledge about the contributing factors. These contributing factors are my learning objectives for today's presentation. And there are 3 learning objectives. The first is the healthcare system. It's important that we all recognize how the system itself has characteristics which relate to and contribute to healthcare disparities. First of all, what we have is not a healthcare system. Systems are, by construct, supposed to be cohesive. Our healthcare system is a very loose collaboration among physicians and other health institutions and other kinds of healthcare providers. Indeed, it is not one system that you step into, and it varies all over the country. Our healthcare system is really not a health system. It's a disease care system. It's structured around disease, not health. If you're healthy, how many of you are healthy and go to the clinic, go to see the doctor? A few of you go for preventive reasons, and that's a good thing. But the system itself is not structured to handle health promotion or disease prevention. It's also insurance-based. If you don't have insurance, to a large extent, you don't get the kind of care that you need. Our healthcare system has perverse incentives. It works best when you're sick, and it does not engage when you're not sick. It pays for sickness, not for health. And so the system itself stays focused on disease, not on keeping you healthy. We all remember our early experiments with health maintenance organizations that didn't survive. Our system is set up based upon insurance. There are two kinds. It's either public or private. Public insurance includes the Veterans Administration. But two systems, two payment systems, public and private. The public systems, in addition to the VA, are, and you know, what are they? Medicaid and Medicare. As my husband always gets them confused. What does care cover? What does care cover? Medicare cover. Okay, and Medicaid covers the poor. So, most of the private insurance is linked to employment. In this country, quite frankly, if you're not elderly and you're not poor and you're not employed, you have no way of getting insurance, except with the most recent advent of the Accountable Care Act. It allows you to buy insurance, and it prices it according to your own financial status. There's a pay differential between public and private insurance plans. Which one pays more? Private, which means with the perverse incentives toward reimbursement, which patients have an easier time being seen? Privates. And which patients, if you're talking about private insurance, Medicare or Medicaid, which patients have the more difficult time being seen? Medicaid. Because, you know, in this country, it's against the law to discriminate against people based on race, religion, gender, national origin, age, sexual orientation, all of those things, but not based upon economic status. So you find even though there are patients who have Medicaid, they are unable to get the kind of access that private patients get because the insurance doesn't pay as well. And although we often refer to our healthcare system as a market-based system, markets tend to flourish through competition with quality or value. Our system our healthcare system doesn't react that way. It does not compete based upon quality, although we're hoping that the value system, if it's part of the payment process, will shift the healthcare system in the direction in which we need for it to go. Now let's talk about the pipeline. Aren't you wonderful? Now we're going to start all over again. Let's talk about the pipeline. When we say pipeline, we're usually talking about a particular group that's not well represented in the medical professions. And it goes without saying that minorities are underrepresented in all of the health professions, particularly in medicine. And this is important because more and more there's a clear appreciation of the fact that you need to have a lot of cultural competency, cultural awareness. By meeting people of different cultures is a way, quite frankly, to acculturate or to professionalize our health care workforce as our providers as they deliver care. And if indeed, and that educational in the classroom, go forth to practice in whatever their chosen fields are. But those minorities, the pipeline for those minorities into the health professions is very narrow, and is very narrow for a whole series of reasons. And the further you go up the chain to education into the different health professions, the smaller that pipeline becomes. Cultural competency has been researched over and over again, and we recognize that in order to deliver care to a segment of the population that is growing and will continue to grow, at least with projections, as I said earlier, of being 50% of the population somewhere between 2030 and 2050. It's important for the care of those populations and for that we have diversity of the workforce that reflects the population that's being served. It's in that context that cultural competency can begin to be achieved. The other reason is, and this goes back for years, having minorities as part of the health workforce helps to identify and focus on those research issues that will contribute to the care and the quality that minorities receive. That's even more important because of the legacy of Tuskegee and other research initiatives in which minorities don't trust being included in research studies, and that lingers today. You try and do a research study and recruit minorities into these studies, and it's very difficult. You have a population, particularly African Americans, who do not trust the system. Having a workforce that's more diverse would facilitate a lot more trust, as well as value in what research could do for minority populations. But the pipeline for minorities as a group is narrow for really fundamental reasons. There's a low rate of high school graduation by minorities. Performance on standardized exams are lower for minority groups than for majorities. There's a low rate of college attendance, extremely low, when you consider the size of the population. The rate of college graduation is even lower than that. And then, of course, we have the cost of higher education. When you have minorities who are disproportionately economic or low economically based. So, there are a whole series of reasons why the pipeline is so small and why it is so difficult to recruit minorities into the health professions. Having said that, though, part of the problem is institutional. I can't tell you how many times I have discussions with my dean colleagues from all over the country who will say, you know, we'll admit minorities every day if we could just find a qualified minority. And quite frankly, none of us know what the characteristics of a qualified applicant is. We do know that minorities are not as competitive when it comes to grade points and MCAT scores and other kinds of standardized exams. But it doesn't mean that they're not qualified. because none of us know what the exact qualification it takes to become a good health care provider. None of us know. And in fact, as we've seen great inflation over the years, today a minority with a 2.8 grade point average probably would not be admitted to most of our health professional programs. However, 10 years ago, 2.8 was okay, bottom half, but you could get in. And these people are successful today and are practicing. So the issue is not that they're not qualified, they're not competitive. If I have a minority with a 3.0 grade point average, when the class as a whole's grade point average is 3.6, doesn't mean the minority is not qualified. It means the minority is not competitive for the seat. So, let's talk about the American healthcare system more. The American healthcare system has been described as capable of delivering the absolute best, most sophisticated, highest quality healthcare in the entire world. People from all over the world come to the United States to get healthcare. The best. But at the same time, the system that delivers this wonderful care has been described for decades as being in crisis. So what is that crisis when we talk about healthcare? The crisis is usually described in terms of access, cost, and quality. However, I'd like to present to you today a fourth crisis: access, cost, quality, and behaviors. Whenever I speak to an audience full of healthcare providers, and I introduce this concept of behavior as being a crisis in healthcare, the professionals immediately say, yes, I agree with that. Because I know patients don't comply, and or patients sue over everything. That's what the health professionals say. But behaviors, as a term, is much broader than patient behaviors. It includes health system complexity, the behavior of the system, a system that's gotten so complex that we now have created a new profession, and they're called patient navigators. Secondly, it also includes the detrimental health professional behaviors born out of cultural insensitivity, biased assumptions, unrealistic and unspoken expectations, and finally, a critical lack of appreciation for the social determinants of health. That's what behaviors are about, not just patients, but also health professionals. These crisis characteristics, access, cost, quality, behaviors, contribute to the sustained inequities and disparities plaguing our country almost everywhere. The inequities and disparities in healthcare, particularly as they relate to the health vulnerable and minority populations, again, have been a scandal for so long that it's lost the ability to shock us. We run the risk of continued complacency and ingrained acceptance of persistent and increasingly unhealthy American population. We must be more vigilant in order to solve the health crises of the Delta. It is necessary to first recognize that a problem exists, and we all recognize that a problem exists. The second thing that's necessary in order to really focus and make a difference in the Delta is that we have to relate to the problem. Some of us do, not all of us. And thirdly, we have to relate to the solution. So whatever it is that we come up with, whatever the strategies are to make things better, we have to relate to those strategies in order to provide the broad-based commitment that's necessary to make the transformations and changes that are needed. It's a sad fact, though, but it's a reality, that parity and equity will only be achieved when the value in eliminating inequities will be recognized and appreciated in economic, political, and human terms. For those of us who believe that health care is a right, we must acknowledge that our current healthcare system is not organized to support that belief. And then for those of us who believe that the healthcare is a privilege, we must be prepared for the consequences of an unhealthy, economically compromised, globally non-competitive American society. So, in addition to the system challenges, what are these social determinants that also play a role in health disparities? And I'm sure if we went around the room, many of you could think of some of those. The social determinants of health. Socioeconomic status. We all know that being poor is the most likely reason for why people suffer from conditions that could be addressed or prevented. Race, ethnicity, one of the second determinants of health. Sexual orientation, gender, disability status, geographic location, age, and then there are societal conditions like racism or discrimination, job opportunities. You do remember that insurance card comes with employment. Housing, poor housing, living in unsafe communities, having access to health care. There are whole counties in the Delta that can't provide adequate access to care. And then opportunities for education, because education makes a difference. But now I want to introduce a term that you may not have heard before. And that term is syndemics. S-Y-N-D-E-M-I-C-S. How many of you have heard that? Let me define it for you. Syndemics is the synergistic interaction of diseases and social conditions at the population level. It tends to occur under the conditions of health disparity caused by poverty, lack of opportunity, and discrimination. And it contributes to a significant burden of disease in affected populations. We can't talk about making a population healthy without looking at the social determinants and then figuring out a way that we can de-link them and improve both the social side as well as the health side. The problem in disparities has just become more complicated and more broad-based. Transforming healthcare in the Delta will require multiple diverse perspectives like health professionals, politicians, public health professionals, social workers, behaviorists, elected officials, and let's not forget the community and community leaders. They have to all work together, all of these different perspectives, to meet the challenge of syndemic. Engage social policy, promote healthy behaviors, enhance educational opportunities, empower communities, and re-engineer the healthcare system. Have to do all of this to effectively bridge the social and cultural issues contributing to healthcare disparities. So in short, eliminating disparities requires a cultural change. We've got to look at disparities differently, and we have to feel and be committed to the fact that we can change this. But let me close by saying there are no short-term fixes, no quick solutions, no silver bullets, no single enemy, and no magic wands. Healthcare disparities is going to take work. And at some point, as a region and as a nation, we have to make the commitment. Eliminating disparities requires sustained commitment through changing times, changing events, changing resources, and changing political priorities. It's got to be the rock that keeps moving forward. More importantly, as I said earlier, and I think it's important for all of us to recognize this, eliminating disparities will require recognition of the value of that elimination in real economic, political, and human terms. So I want to thank you for inviting me to speak. I apologize for the fact that I can't see in the dark. But the good part about this whole thing is I wanted to get through this part quickly, because the fun part for me is being able to speak to each of you and talk to all of you and get your questions, your perspective. Okay? Now, I'll answer any question. Hopefully you will ask some about the new medical school. Okay? I'll answer any questions. If you don't ask questions, I'll go around and pick on you and ask you a question. That'll be embarrassing, so if you don't want that to happen, now's the time to step up, and I'm here to ask questions to you.
Okay, Dr. Rusley, can you talk a little bit about some of the strategies that you're thinking about that you might incorporate into your osteopathic curriculum, since you're going to have a lot of medical students, residents in our region that might help with the access, the understanding, the syndemics? Can you talk a little bit about what you've been thinking about for your curriculum preparation?
Yeah, well, number one, we will train or educate our students as much as possible in the communities of need, so they're not intimidated by the concept once they get out into practice. Great, that's good. Can you hear me? So they're not intimidated once they get out into practice by the disparities that we see in minority communities. So that they're comfortable and they're somewhat competent, culturally competent. Having said that, my belief is, and I want us to, because when you start talking cultural competency, particularly when you're talking to the majority population, they feel somehow challenged, you know, that there's some bias there that, quite frankly, they don't have. the reality is we all have biases. And I'm a family physician. And one of the things I learned really early in my practice, every clinician-patient interaction, every single one is a cultural interaction. Whether they look like me or not, we're different. We all come from different backgrounds. We're kind of a hodgepodge. And if you can relate to the fact that if you look just like me and you're one of my patients I'm talking to, and I'm sensitive to the issue that we may have cultural differences that become a barrier in my ability to be able to treat you and get the best quality results, then, my goodness, I can do the same thing for any other racial or ethnic group that patient that I interact with. Every patient encounter, every clinician-patient interaction is a cultural interactions. Some broader than others, some deeper than others, but every single one is different. And that's what cultural competency is all about. That you are aware when you start talking to that patient that there may be a different culture, and you make allowances for that, and you try and understand that particular person's health-seeking behaviors and lifestyle. Did I answer it for you?
Anything about health literacy, population health?
Yeah. One of the things, well, for health literacy, and one of the challenges and one of the social determinants is education. Studies show over and over again that the more education the person has, the better they are able to manage their own health and the health of their loved ones. We see that with pregnant mothers or mothers with young children, that there are better outcomes. Children are vaccinated on a regular schedule, just like they're supposed to be, if the mother has a certain level of educational attainment. Education is important. You would think, given all of the technology, that wouldn't be something that we would have to continually stress. But you know what? Certainly the media is usually trying to either entertain or sell something. And it's not always factual education. Literacy, health literacy is important. It needs to be taught in the schools. It needs to be a part of our K-12 system so that students can speak about it, because if the students learn, they take it home and teach mom. That was very effective in Stop Smoking. So, yes, literacy is extremely important. As it relates to population health, that's where we get this burden of disease. If you can't look at a population, if you can't apply strategies that will make specific populations better, classically as a population disparity, infant mortality is one of the ones that we look at a lot, you know. That ultimately, once you identify populations and a disease process or an unhealthy state, then you can determine strategies that will have a broader impact than if you're doing it one person by one person. Although one of the downsides of health professional education is we teach our students to focus on that person right in front of them. And it's hard for them then to be able to look at broader populations, to think about the population as they're treating that one patient. But it's an adjustment we have to make. Now, one of the things that we are doing with our students, and we will be doing with the students here at Arkansas State, is integrating much more technology in trying to reach out and engage patients in a way that's comfortable and non-threatening. We're going to do a lot with telemedicine. not so much delivering it ourselves, but encouraging our colleagues in the community to use the technology, and expose every single student to the emerging technology. And I mean, it's changing fast when we start talking about technologies. Medicine has been one of the last, what can I say, industries to accept and utilize technology in an effective manner. But we're going to start, or we're starting to see now, a lot of those changes. So you're going to see, when you go into your doctor's office, you might see that cardiologist who's in Little Rock, you know? Particularly for areas like rural areas where they're not a broad-based specialist anywhere, and shortages in primary care providers. And so therefore the technology is going to become part of the solution. We've been playing around with telemedicine for almost 2 decades now, but the technology is better. So we're going to expose our students to a lot more technology so they're comfortable with it, and hopefully be able to take it to communities so the communities become comfortable with it as well. Other questions? Yes, ma'am.
What role does the healthcare providers play in narrowing that health disparities gap? I know that some physicians won't even take patients that have Medicaid.
Yeah. That's part of the perverse incentives. That's a system problem, in that physicians earn their dollars based upon their interactions with the patients, usually through procedures. Medicaid pays very little for a procedure, whereas private insurance pay a lot. So if you had a choice between, if you had a choice between taking a Medicaid patient and a private insurance patient, which one would you take? It has less to do with the population health issues. It's a business issue. I can remember when I was in practice, my office assistant came to me one day and she said, you know, you're really good to your patients. You see your patients whether they have insurance, Medicaid, you don't care what it is, you just take care of your patients. And they love you. And they're getting better, you know, they're healthier, you know, they're complying with all instructions, they come back when they're supposed to. She said, you're just a wonderful doctor. She said, I wonder if the next doctor who was going to take your place, because you're going bankrupt, I wonder if that doctor is going to be as good as you. And you know, these are the issues that physicians play. You know, these are the issues it's just not a choice, it's an economic issue for physicians. It really is. Because ultimately you got to keep your doors open. So it's not always a bias, but it does, the system itself, because the system has structured the payments base. That's part of the problem. So the incentive is not to see Medicaid patients. Of course, you know, there's another, I talk to students all over the country, and you know, Medicare pays for residency training, for training physicians as specialists. You know that? How many of you knew that? I love it. I love it. Medicare pays for the education of specialists. Did you know that? Medicare. All over the country, Medicare pays for specialty training. But we have, and residents, they don't make bad money, by the way. It's certainly a livable wage. While they're training, they are being paid by Medicare through the hospitals. The Medicare gives the money to the hospitals to pay the resident. So most of the residents think they're working for the hospital. They don't have any idea where the money came from. The money came from Medicare. Medicine is the only profession, by the way, in which the government pays for half that training. which is the residency training portion of it. So Medicare pays for that. There is no requirement that when the physician at this point, when the resident finishes their training, becomes a specialist and go out to practice, there's no requirement that they will treat Medicare patients. Because Medicare doesn't pay as much as private insurance either, by the way. There's no requirement. So this is a very perverse system with a lot of things that need to change or could change. But it's grown up over time, which is why when I say we need to re-engineer, we got to get far enough or high enough to look down at this whole system and see what's not working. Because there are a lot of pieces that are not efficient or effective and are not working and become part of the problem when you're trying to address issues like disparities. And I tell my physician friends that part of the reason we have so many intrusions into the care of our patients with regulations and laws and reimbursement and insurance companies and health records and all of this is because physicians didn't pay attention to the big picture. They were just looking at the patient in front of them. And because they didn't, now you have other agencies that have stepped in and made requirements. Okay? And physicians are demoralized because they have to fill out a piece of paper, I think probably for everything, and most of it is not online. Okay. Question? Okay, how many of you know what an osteopathic physician is? Oh, this is really good. Oh. Did I see a hand over here?
You saw me, Dr. Lee.
Yeah.
My question is, will the differences in allopathic and osteopathic medical systems make a difference at the community level? Because many people don't know that, no medical doctors, few know a little bit about osteopathic medicine, but will community education be needed? Got 3 questions.
You know, absolutely. I think if I can answer it simply, then we can get down to the more details. There are 2 schools in this country that produce physicians. One is called allopathic, and the other is osteopathic. Allopathic schools produce MDs. Osteopathic schools produce DOs. Now, if I could make a parallel, it's sort of like getting a high school diploma from a public school and a parochial school. They're both high school diplomas, but the philosophy of the education in those 2 systems of education are a little bit different, but they have to meet the same requirements for graduation from high school. They have to have the same proficiencies. They take the same standardized tests. They qualify for the same kinds of jobs or for higher education. So it's a philosophic difference. And a lot, quite frankly, for osteopathic medicine, it's historical. I'm an osteopathic physician. From my perspective, the name is a little bit unfortunate, because you keep saying osteopathic and you think that immediately it means bones. Let me just give you a brief picture of how it got started. In the late 1800s, 1885, something like that, the founder of osteopathic medicine is an MD, or was an MD. And medicine was practiced really poorly in the late 1800s. People were dying from the treatments as fast as they were from the diseases. It wasn't practiced well at all. They were doing things like bloodletting and using all kinds of toxic drugs to cure patients. The founder of the osteopathic profession, A.T. Still, said, this is not right. You're killing patients. Your job should be the body has the capacity to heal itself. Your job should be to promote the body's healing potential, not to provide poisons. And so there was a split. And that split became osteopathic medicine and allopathic medicine. Less than 10 years later, a man by the name of Abraham Flexner was commissioned by the government to look at the look at physician training because healthcare was so bad. And based upon his study, medical education was formed, but osteopathic medicine, who had split off, was on the outside. And so you had two parallel systems of producing physicians moving forward from that day forward. There's very little that I tell my students that the difference as an academic in what we teach osteopathic physicians compared to allopathic physicians. We spend a lot of time teaching our students how to use their hands. A lot of time. It's additional in the curriculum. Other than that, other than the time we teach our students to use their hands, to touch patients, and touching patients, by the way, communicates caring. We teach them how to touch patients. We teach them how to treat some musculoskeletal conditions, okay? And we use our hands as a communication tool with the patient. MDs don't have that in their curriculum. We also focus heavily on the generalist specialties like family medicine, internal medicine, pediatrics, OB-GYN. Doesn't mean we don't have neurosurgeons, orthopedic surgeons, emergency room physicians, but it means that we stay focused by having our training in the community early as we possibly can, teaching our students how to use their hands so they can better communicate and feel more comfortable and confident in the generalist disciplines, okay? And we recruit and admit students who are interested in primary care. People call them primary care. I don't like the term primary care. Primary care is a set of services, is not a discipline. You know? Okay. Because all physicians, even the orthopedic surgeons or the cardiac surgeons, deliver some primary care. Okay? Primary care is a set of services. So that's what osteopathic medicine is. It is a parallel profession. It is growing. It is the fastest growing health profession in the country. We have gone in the last few years from 16 to now 35 osteopathic medical schools. Actually, it's from 16 to 29 osteopathic medical schools at 35 locations, which counts what we're doing here at Arkansas State. We are just an extension of the New York school, okay? We're an additional site, so we're part of that school, but we're located at a different place. Yes, ma'am?
Why is it growing?
Because there's a shortage of physicians, and as a minority profession, if you don't grow, you die. And so that was the initial impetus, was to continue to feed the base. We needed to have students who would continue to practice osteopathic medicine. But then we were confronted with a significant shortage in this country. So much so, by the way, had many schools going offshore to get training to come back because they can't get in medical schools, okay? And because of that, we grew faster. We could grow faster because the way osteopathic education is organized. So that's part of the reason why the shortage. And many of the osteopathic schools, although that's changing somewhat now, are located in areas of the country that have high rural populations or rural geographic areas. Kansas, Missouri. I'm a graduate from Michigan State. not really rural. A lot of urban, though, in Michigan.
Dr. Lee, Peggy Wright again from the Delta Studies Center. My last question. Will there have to be special training for nurses and social workers and allied health workers to work with the different osteopathic doctors?
Now, you know, we've got a challenge in medicine, and it's just not osteopathic, it's medicine, to be able to bring all these disciplines together as a team, because it delivers a higher quality of care. But we don't have many, we have a few. We don't have many team models in which we can train our students. So we have to create the team models to expose our students, because if the students aren't exposed to teams, they won't feel comfortable practicing in teams. I will tell you, in this area, because of the need to deliver healthcare services in a more efficient and effective manner, we have more opportunities to expose our students to teams than we do in New York. Okay? New York, quite frankly, is subspecialty heaven, you know? Although my medical school in New York still produces over 50% of their graduates go into primary care. I think it's 56%. The average for MD medicine is something like 34%. So, and we're very proud of that. We're also one of the most diverse schools in the country. I like to think I had something to do with that. Yes?
Since the
You all aren't asking really hard questions. I thought
Since the osteopathic schools are growing, does this mean that you're getting back to your roots and your basic philosophy of holistic medicine? Because frankly, to be honest, I've had several DOs as my physicians, and I didn't see the difference between the MD and the DO. And that concerned me. I have one now, and I don't see that. So I think it's just a result of, you know, everything that's going on with the system. They have to see patients in a certain amount of time, and they don't have the time to spend with you that they should. So they're not really practicing that holistic view of medicine.
You remember that in order to pay the bills and the people who work for you, you got to see a certain number of patients, or you close shop and nobody has a doc, right? As long as I think we lean too heavily on that. I think we, as physicians, could do more to see patients and spend more time with patients. I think it's become too easy of an excuse not to find ways in which to be able to do some of that. But holistic is more philosophy than anything else. There isn't a generalist physician or a primary care physician, MD or DO, that doesn't practice holistically because they have to, because we're looking at the whole body. We're just not, you know, I say, actually it's a joke if you all promise not to tell. There's a joke that says we have generalist physicians and we have partialist physicians. The partialists are the specialists, you know. Okay, you got it? Okay. So, no, if you're a generalist, if you are family medicine or general internal medicine, pediatric, you have to be holistic. It's just part of who you are. So you wouldn't be able to put your finger on, they did this holistically. Okay. I will tell you what we get feedback on is, remember all that time I told you we took to train our students in how to use their hands to diagnose patients, to treat patients, and to communicate with patients? That gets translated by patients into that doctor is really caring. And so often I jokingly tell people, if you have a doctor and you think that doctor really is caring, a caring physician, cares a lot about you, and the reality is he's probably a DL. They did studies a few years ago in Michigan, Wayne State University, to say that those patients who the doctor touched felt that that physician spent more time with them than they actually did, just because they touched them. And you would be surprised at how many physicians do not use their hands that way. But it becomes second nature to osteopathic physicians because they're trained from day one to touch. Just one of those unintended consequences.
Dr. Lee, you got me thinking, when you talked about educational disparities and how well people do with healthcare for young children, I'm doing some research in autism and sort of disparities between rural communities and providing in schools, particularly like relational issues between school administrators and parents and getting the proper services while in school. My question is, in terms of helping people in ethnic minority populations to understand signs and symptoms of autism and to go in earlier. They're getting late diagnoses, if at all. Any suggestions on how to engage minority populations, particularly African American, to recognize that these are signs and symptoms of a pervasive developmental disorder?
Yeah, it is. For populations that are poor with heavy disparity loads and seek health care late for themselves, use emergency rooms as the kind of there is a cultural denial, and I think that's what happens a lot with autism. It's a denial until everybody in the neighborhood tells you there's something wrong with this kid.
Well, and physicians aren't taking people seriously either, unfortunately.
Yes, yes, it's just, and yeah, education will help that, but you won't, from a population base, you won't see really big changes in the short term. It's going to be a long-term set of issues.
Makes sense.
It's interesting you should say that, because that use your hands thing. I visited China and we were collaborating on a research project on autism, because the Chinese use traditional Chinese procedures to treat autistic children, and they are having amazing results. So we wanted to include some of the traditional osteopathic techniques to see if that enhanced it or if it made any difference whatsoever based upon their outcomes, you know? Because there are some osteopathic techniques that physicians in California are using on autism, okay? But they're OMT specialists. I just do your back hurts, I'll fix you. I can't do autism.
Not yet, anyway.
Absolutely. Other questions? By the way, we will have 115 students in each class here in Arkansas. We expect to start the program August of next year. For how many of you are in academia as faculty or staff? Well, we're going through the accreditation process. That is so much fun. I can't even tell you how much fun we're having. But we expect, and each one, you know, it's been good. It's just that there's another one after it. And actually, we have another scheduled meeting with the accreditors in December, and we will have another one in March. And then we will have, they've already told us this, it doesn't matter where we are in the process, but so we're expecting to open August of 2016 with a class of 115 students. However, we can't start recruiting until they turn the green light on, and they're supposed to turn it on at the meeting in December, so that's where we are for recruiting students. We are now recruiting faculty and staff.
Do you have any suggestions as it relates to the disparities between intellectual acceptance of issues and the emotional component? I find so prevalent in racial issues that one can intellectually accept the fact that we're equal, everything's okay, but at the same time I can sense an emotional response that is not consistent with accepting the fact that we are equal.
I think that's maybe a cultural issue of vulnerability. If you don't feel empowered in the system, I hear you. I understand what you're saying. But I can't accept it fully because I'm vulnerable. I don't have options, you know? And so I think you will find that on any depressed population, okay? If they are vulnerable for whatever reason, age, see it in the elderly, whatever the reason is, there is that real, I hear it, I understand it, but if you sort of like if I embrace it, it becomes real, and then I'm powerless. So I hold on to that little bit of power that I have.
Try to teach students that feelings are not factual, and yet they are to a degree.
Yeah. Yeah. But what you wind up from a cultural standpoint, treating more than the facts are the feelings. That's the cultural component. That's the competency there. You got to treat the feelings or you're never going to get to, you know, the objective facts. Yes, ma'am.
Can you elaborate on the recruitment and application process? Could someone apply directly for this site, or is it dispersed among all?
Let me tell you how the application structure works. We have a national application pool, so you apply to a national site. It's the American Association of Colleges of Osteopathic Medicine Applicant Service. ACOMAS, we call it. I really feel good that I was able to do that, by the way. And you apply there, and when you apply, you have a sheet that essentially, and you can apply to every school that you're interested in. This site will be, I think maybe the first year, this site will be listed under in the New York school. So it'll be the New York College of Osteopathic Medicine at New York Institute of Technology, and below it it'll have Old Westbury, New York, and then Arkansas State. So you'll be able to choose, okay? Yeah, you'll be able to choose. Most people check both, okay? Play the odds, okay?
When it comes to osteopathic medicine and with relation to allopathic medicine, would you say that it's fair to say that osteopathic could be a blend of naturopathic and allopathic, or is it completely in its own section?
It's completely in its own section.
Because you mentioned that
It's
the
not.
Chinese
It's
were
not a
using-
blend with chiropractic or anything.
Okay.
Okay, it's completely in its own. Although what I will say is that more and more MDs and DOs are coming together. Right now, for residency training, we only have one system of residency training, and both DOs and MDs go into that residency process. So more and more, you know, I'm a minority, and Lord knows in my family I've experienced enough health disparities. But more and more you learn separate is not equal, and that it's much more efficient for the populations that we serve to come together on things that we're doing exactly the same with very little difference, and build those into one system rather than two. It's less expensive too, by the way. So no, osteopathic medicine has a philosophy, and it's based on structure is related to function. So if the structure is not correct or out of line, you can't function the same. Logic, right? Much of what osteopathic medicine had as a philosophy has now been incorporated into MD medicine as part of science anyway. And so to a large extent, you're seeing the professions merge. In my part of, or I should say in the Midwest particularly, you know, DOs and MDs are working together. You can't tell the difference, as somebody said earlier. You just can't tell the difference, which to some extent is a shame, because I think we bring something to the clinical arena that MDs don't bring. Although, by the way, part of the merger of the residency training programs into one system, many of the MDs want that osteopathic manual medicine training that we give our undergraduate students. That's a challenge for us. We're trying to figure out how to do that. Okay? Very much in demand, though. Very effective. Yes, sir.
So, kind of two questions. With the osteopathic medical school coming on campus, with that being private, is there, since there's a need for family physicians in Arkansas, is there going to be, focused on getting students within this state, or is there any type of preference? And then my second question, with the increasing number of medical schools, is there concerns with residency placement after graduation?
One of the requirements, I'll take your second one first. One of the requirements for opening a new osteopathic school is that you have to establish residency programs for these students that you're training. So we have established new residency programs throughout the state of Arkansas and are still in the process of establishing more, so that our students, when they graduate, will have residency programs to go into. Having said that, residency programs are national. Remember, they're paid by Medicare in Washington, D.C. And so graduates from medical school here can apply to any residency program in the country. Part of our job is to establish, what we need to do is make sure that pool is bigger, so that even if they choose a residency program in Montana, the numbers are enough that there will still be other openings, maybe here in Arkansas. Okay? So, yeah, and the first question, can you repeat it?
Is there a preference for
Oh.
Arkansas?
The whole reason why we're doing this, and Arkansas State deserves the credit. The issue is Arkansas, from a health status of its population, is at the very bottom of all 50 states. Arkansas is unhealthy. When it comes to the number of physicians, Arkansas is number 48 out of 50 in the states. When it comes to the health of the Arkansas population, it's 49 or 50 out of 50 states. So, and there are not enough of any kind of the health workforce, specifically physicians. So Arkansas State said, look, we can't afford to build a de novo medical school as part of the state system because it's expensive and the state can't afford it. Maybe we can find an institution that we can partner with, and that institution can bring its programs down here. It needs to be an institution that has a track record in producing the kinds of physicians we need. But the whole point of this effort is to educate physicians in Arkansas to stay and practice in Arkansas. Physicians tend to stay and practice where they train. So not only the undergraduate medical school, but also residency training. That's why we're building both of those pieces together. We also know that people tend to stay in the areas in which they grew up, where they came from. So our focus is to recruit students from Arkansas, or at least from this region, so that they're much more likely to stay in practice here in Arkansas, in those underserved areas. Let me tell you, and the whole state is almost undisturbed, except maybe, when you look at the map, it's unbelievable, folks. Actually, I went back to New York and talked to all my faculty. We were all in tears. For me, this is a need that has lingered too long. Even as we start up in 2016, it's going to take 6-7 years before we actually have physicians out in practice. But in the meantime, we are going to be exposing those students to as much of the need in Arkansas as possible, so that we can get that commitment for them to stay and practice here and have places for them to practice. I thought you were going to ask the question, it's a private school. State schools are cheaper. Private schools are more expensive. So we are more expensive. So part of what will be doing from February, we've got so much to do now, I try to give it a month, and when we're going to start working on this issue. Part of what we're attempting to do now is to identify ways in which we can give scholarships for these students so that the tuition won't be so high. One of the challenges in all of medicine, not just New York's Institute of Technology, but all of the medical schools, the debt load for medicine is now starting to become a real issue with our being able to recruit and retain students who will stay and practice in the generalist specialties or in primary care. Because you can't make as much money in primary care as you can in orthopedic surgery. And it's like day one of practice, an orthopedic surgeon will make 3 times as much money as a family doc.
Dr. Lee, I may be off here. I'm a social worker, but there's the Health Provider Service Organization. If you commit to practicing for 2 years in a rural area as a social worker, you can get up to $60,000.
Give me a
of your
card.
student loans paid off. I sure will.
And the National Health Service Corps, but National Health Service Corps, sometimes you have to leave the state, but that is an option. The issue is the average debt load for medicine, public and private, is $200,000 on the day you graduate. It's too much. It's too much. So now, unless Congress wants to weigh in and hand us some money, and my thought is, in all honesty, that they should be paying, medical school should be what Medicare is paying for. Okay, and let the residents who can practice medicine, medical students can't, they have a way of earning their salary. So, but I was on the IOM committee talking about what they should do for GME. They wouldn't let us talk about undergraduate medical education. It wasn't part of the charge, but that is the feeling. Undergraduate medical education has become so expensive that we've got to figure out a way, or we're turning people off. By the way, the offshore schools, for anybody who's ever applied, has anybody ever applied to an offshore school? No? Okay. They're even more expensive. Any other questions? Okay. I think I've told you all. We are recruiting right now faculty and staff, and starting in January, I think, we will start recruiting for the class of 2016, the starting class. Okay. Thank you all so much.
Good morning. Thank you all for coming. I hope that you all have enjoyed the keynote speaker as much as I have. Certainly she mentioned some things that I have a lot of students here. I have a lot of former students that are returning here. Some of the things that I have stood up in front of the classroom and talked about passionately, the need for more healthcare workers to be culturally competent, and for us to begin to look through the lens of culture when we are serving our target population. I have a gift. I'm going to ask Dr. Rossley to come up. And don't anyone leave yet, because I want to give you all directions, okay? Thank you so much. On behalf of the Social Work Department and the College of Nursing and Health, I'd just like to say thank you so much for taking time out and spending time with us this morning.
I don't have to share it, do I?
No, you don't have to share it. All right. I want to just remind you all that you have evaluation forms that are in your book. That will be on each presentation that we have scheduled for today. I want to encourage you to complete those.
We have our silent auction that is outside. You can begin making bids. We got a little bit of time before our next session starts at 11 o'clock. You have several choices. One thing that we did not mention this morning that I want to make sure that I make mention and remind you all to stop by Centennial Hall. We have several groups of students that have worked very hard. And again, as I listened to the keynote, she talked about some of the topics that the students are going to be presenting their poster presentation on. So I want you to make sure that you stop by Centennial and view the student posters. I think that you will find them very informative. We will be judging, the judges will be judging the student posters at from 12 to 1. So we got a quick break that we will be doing now. Our first track presentation will begin at 11 o'clock. Again, thank you so much for being here.
They said that it was broke. I said, can you just bother to tell somebody?
I am so sorry.
Oh, no, I think.
Well, I don't know why the podium doesn't have an, a light
And I told him, I said, I've spoke before in here, and he said, well, the only one we have is broke.